right. Well, yes, I must say, complicated period. I hope everybody is safe in their environments. This has been an unprecedented time. Italy, you have followed, has been possibly the first European country that has gone through this true mayhem. It was a bit of a disaster, but now we are managing slowly to survive. UK and London is still in lockdown, so it's a little bit complicated. However, let's get directly to the core of this lovely chat this morning. So good morning and good afternoon, because I see people connected from all around the world. So complications, well, we are clinicians, so I like to quote that we face complications on our daily clinical work when we perform complex cases. So once in a while, unfortunately, we have to face complications. But this is why we're here. We are here to improve ourselves and to learn from other experts in order to avoid this as much as possible. Naturally, we have seen beautiful presentations this morning to emphasize the potential of guided bone regeneration when it comes to rebuilding the lost tissues. And we would love to treat our patients in this manner and in the most predictable way, whether it's the anterior, whether it is the posterior, to rebuild the lost tissues. And all of these are our patients that we face on an everyday basis. So let us understand how can we manage when things do not go as expected. GBR, or guided bone regeneration, is a well-known, well-documented technique, and we have one of the fathers of GBR with us, Professor Boozer, who has shown us quite a lot of beautiful literature behind this science, this biology, I would like to say. Guided bone regeneration has allowed us to treat several patients, and I was honored to be part of the latest consensus conference organized by the EFP and the Osteology Foundation in late November. You may recognize familiar faces, where we have analyzed and assessed for quite several days, closed in a room, all the data published in the literature when it comes to three-dimensional GBR. And the reason why I'm bringing your attention to this is because Isvan Urban, who you will hear later on throughout this two-day marathon organized by Geistlich, has published after this in 2019 a systematic review evaluating all the different techniques to increase bone in the vertical dimension. You may recognize guided bone regeneration. Blocks stands for autogenous blocks, whether it's intra or extraoral. DO stands for distraction osteogenesis, and other stands for a group, a category of other techniques which could comprise interpositional block grafts, for example. Now, if we have a look at a little bit of data, certainly we have a very high mean vertical bone gain when distraction osteogenesis is performed. However, you may notice a complication rate, which is almost, I would like to say, unethical, because if 1 out of 2, because this is close to 50% of our patients, has to face a complication, whether it's a minor or whether it's a major complication, this is obviously something we need to question ourselves. Whereas it is interesting to see that guided bone regeneration has brought, in terms of complication rates, the least number, the least percentage. And of course, this is a data deriving from this most recent systematic review. I myself had written a systematic review back in 2008 with the same categorization of techniques, and the big difference between the two systematic reviews, mine was published in 2008, whereas Istvan's has just been recently published last year, is the change of the new generation barrier membranes. Here we are talking about the severe defects where the self-containment of the alveolar defect is non-existent. We're talking about pure vertical defects where we need to reconstruct three-dimensionally the alveolar bone. Once back in the 90s, when I started with Massimo, as Danny was suggesting, we used the expanded PTFE. These were titanium reinforced expanded polytetrafluoroethylene membranes, which brought, by literature, percentages of premature exposure of around between 13, I'd say, and 17%, which was a relatively high number. We have seen there has been a shift in a decrease of percentage of exposure when we have started using dense PTFE. And this is clearly backed up by the most recent publication. Of course, what is a complication and why do we get complications in this very, in a way, risky territory of this kind of interventions? We can have three macro categories. We obviously have the pre-op complications. Pre-op complications comes to the decision making, the wrong diagnosis, the wrong treatment plan, the wrong selection of the patient, the wrong selection of a certain surgical approach. What about the intraoperative complications? This is due to the actual surgical intervention. So it is our act of operating on our patients, and we will see this. And post-op complications may derive from a surgical intervention, which at the moment seems that everything is fine, and I will share with you a case. And of course, also a wrong or an incorrect maintenance regime. But all of this to say, this is obviously a very superficial subdivision. We will go into more details. However, I like to underline and state that within all these three macro categories, there is one common theme, which is ourselves, which is us. We are obviously responsible for every one of this step. So we need to be able to recognize then that the clinician, the operator, is in fact responsible, and not other things such as the material or somebody else or the patient. The patient didn't clean well enough. It is our duty to train the patient, to educate the patient, and again, to select the correct patient if we want to achieve success. I would like to share with you a video of an intraoperative complications. Paul is a lovely gentleman who was referred to me, and we treated him during one of our courses or masterclasses. And I'd like to share with you this video showing you an intraoperative complication. I hope that this will, that you can see the video clear enough. It is not necessarily an extremely complex case, but certainly it is a highly aesthetic area. He's a young gentleman, and we are regenerating the anterior due to the lost central and lateral incisor. You may notice here now the bleeding which will occur. Here, it doesn't seem excessive because of the video. However, you need to trust me, it was very, very copious, and it was an intraoperative complication which we need to face. We need to learn our anatomy, we need to deal with the bundle of the incisal canal, and we need to treat this if this happens. This was treated by cauterizing the inside of the incisal canal, and then the surgery carried on in exactly the same manner, the same protocol. We don't have time to go through the protocol, and this is not the time to do it, but every single step is always followed according to very specific guidelines. This is the release of the periosteum, because we know that the flap management is one of the critical factors, and we want to release those flaps that we can literally have a complete tension-free suture area in order to avoid premature exposure. Now let me get more into the details. Now this case had that intraoperative small complication, which was really managed. It was just a matter of being very calm, recognizing, knowing what to do, and carrying on as expected. The case was then finalized. It was 6 months after the bone regeneration occurred. I reopened the patient. We can see a nice, beautiful regenerated ridge that then allows, I like this image because it is highly vascularized. It allows to position our implants in the correct 3D position and then proceed with the final restoration, and the patient is ready to to finish, and a nice, satisfied patient. I like the contours, it's quite harmonious, it's a screw retain restoration, and the patient is happy. So let's get into a little bit more of details of how we can prevent these things. Now, some of you may have already seen this case, because it taught me probably one of the biggest lessons. And I want to also highlight that these cases are my complications, and I think it's also very wise to show and not to be afraid of showing anything that may go wrong in our own hands, because as I said at the very beginning, if you are a clinician who works on an everyday basis, these things may happen. Delphine is a patient who was referred to me. You may notice it's a very or relatively simple case. The soft tissues are beautiful. She had lost this lateral incisor spontaneously due to a loss of clinical attachment loss all around, so a periodontal disease that was in her life untreated. And this, you may notice, has affected also the lateral incisor with a large recession and a clinical attachment loss on both the central incisor and the lateral, and the canine, apology. So you may notice that when we see a case like this, you start talking to your patient, and you start assessing and telling the patient that you may need to compensate with prosthetic solutions, as we saw earlier on, in order to avoid the black triangles between the future prosthetic restoration, or simply accept the black triangles. So let's get into a little bit of the detail of what happened that day. So the surgery, as I said, the protocol of vertical GBR is always identical, the same flap design, the same technique, the same instruments. We tend not to alter this, because it is crucially important that we train ourselves to perform in a very strict manner this protocol, because this is a surgery that really does not allow any shortcuts. You really need to be precise in every step. You may notice the defect is not necessarily massive nor severe. We may confirm the clinical attachment loss at the adjacent teeth, and there is a thin ridge which does not allow a simultaneous implant placement in the correct 3D position, but we have a small vertical component. However, we do need something that would stabilize the blood clot. I obviously did not go into the details of the biological principles of GBR, because I think these are well known, and this is not we don't have enough time. However, you may notice that from this slide, during the actual surgery, something doesn't look really good. This is a tenting screw. The tenting screw comes originally when we started learning. I started learning from Massimo many years ago, and it was meant to be used as an umbrella pole, to hold even more, to give more stability to the overlying membrane. Now, in a space as small as this one, this is completely unnecessary, and especially nowadays with the new generation titanium reinforced membranes, these membranes have a reinforcement which is bigger, which is more pronounced compared to the previous membranes. So this was completely unnecessary. Nevertheless, because in my mind I had this kind of training, I carried on using this without realizing and understanding, until I had a complication. This is the reason why I like this picture, because it really shows the big mistake I have done. This screw is malpositioned. The screw is too much buccal and too much coronal. And the strange thing is that now that I see this picture, and thankfully I document every single case we do, we document both from video and photographic, and this is the only way you can improve yourself. The strange thing is that I didn't realize at that specific time that this screw was in a completely different, wrong direction. So I carry on with my surgery. And again, this is really interesting. Why didn't I see that it was wrong? Look how, when I positioned the particulated graft, which is a mixture of autogenous bone harvested in the same area from the nasal spine to decrease the morbidity postoperatively, and 50% of bios or xenograft, you may notice that I can still see the head of the tenting screw. We have a golden rule, which brings us to position, when this was necessary, the tenting screw at the level or slightly below of an imaginary horizontal line going from bony peak to bony peak. And this is clearly outside this bony peak line. So I really don't know why I did this, but still I did it. So I carry on and I'll show you what happened. The suture was tension-free. Everything was following exactly the same protocol, 2 lines of suture, horizontal mattress, interrupted with Proline, everything following exactly what we have been trained for. And unfortunately, only at month 2, not earlier, so not on the incision line, as you may notice, we have a surprise, a terrible surprise. We have a soft tissue dehiscence. And guess what? That soft tissue dehiscence is exactly at the level of the head of the screw, which was positioned way too buccal, hence putting too much pressure on the overlying soft tissue. And we perfectly know that the pressure on these soft tissues is very bad, because it causes a soft tissue dehiscence. And this is definitely the proof of it. Now, at that time, again, this was quite a few years ago, we didn't know much about how to treat dehiscences with these new generation membranes. So I tried my best to look it up, to look into the literature, to find books, to find colleagues. And the funny thing is that when you have a complication and you try to ask for some help, most of the people tell you that it never happened to them, so they don't know what to do, and you scratch your head and you try your best. But yet again, I did another mistake, which was removing the exposed part of the PTFE, showing the screw. And I have a highlight of this. You can notice also the titanium reinforcement. Now, the reason I did this, there was a rationale. Because when we were using the expanded PTFE membranes, the old Gore membranes, Massimo Simile in '94 had clearly shown us through a nice study that bacteria would penetrate this exposed membrane in 4 weeks. So you had a time frame of 4 weeks to intervene. So I said, well, just in case not to have any problem with the exposure of this membrane, let's get rid of the membrane. So this is what I did. Now, a lot of people have asked me, why didn't you take the screw out? And the reason why I didn't was because, going back to the biological principles of GBR, at month 2, there is the maximum potential from the body for the neovascularization, for the neoangiogenesis, and everything has to be completely immobile. So in my mind, removing the screw at this stage would have disrupted this process, potentially creating even more damage by infiltration of connective tissue inside. So I just wanted to avoid this. So I left it, and I left it to be watched. And obviously the patient was monitored on a weekly basis, even though she was living quite far. And even that is one of these aspects that we always have to encounter in our profession. The management of the patients. We don't control our patients. Sometimes, unfortunately, they live far, or they live even worse abroad, or they're very, very busy. So we really have to make sure we tick all those boxes when we are meeting the patient. And after 2 months, you can notice the soft tissues really do not like the exposed membrane, and this is pretty clear and now pretty obvious. But back then, I was hoping that the soft tissue would not increase its dimension, but I was wrong. The lucky part of all of this learning curve of this case was that there was no infection. You can notice that the soft tissues do appear healthy after all. So at this stage, because we normally wait for 6 months, we are basically 3/4 down the line, I told the patient, Delphine, we really need to open up this site and get rid of that membrane immediately, get rid of the screw, and see what happened and manage this complication. Delphine is a lovely patient, but she was a little bit anxious, and she's always wanted to have surgery under IV sedation. And because we need an anesthetist to do this, I booked her in for the following Monday. It was on a Thursday. I canceled the patients, and we dedicated the whole morning to Delphine. Now, the following day, and this is sadly a true story, the following day, the daughter calls in and says, well, I'm terribly sorry, but my mom didn't have the courage to say that she left for a holiday for 1 month on a cruise ship. So she's gone for a whole month. So we were very, very worried, and I was worried. So obviously we kept in touch, and I gave her showers of chlorhexidine. There was obviously no infection. I must say that the patient was feeling absolutely nothing. And lucky me, she had a low lip line, hence she was not seeing this. However, this doesn't refrain from the fact that this was a complex complication. So I was very worried, and I will share with you now what happened in just 1 month. There we go. So in just 1 month, we've gone from a complex soft tissue breakage or dehiscence to an extremely humongous soft tissue dehiscence. Now, you must believe that white substance that you see is not pus, so there was still no infection, but it is plaque. So the area was still looking relatively healthy, if that's what we can say, but a disaster from a soft tissue point of view. So at that stage, there was nothing else that I could say, if not, please stay in, we need to really open this. So we performed the surgery, and to my surprise, when I reopened, it was completely solid. The most apical portion was in fact intact. So I went on removing everything I could have, and the actual area had gone through the regenerative process. Of course, we had lost some tissue in the most in the most coronal position because of the screw and because obviously of the soft tissue dehiscence. But if we get a closer look, and I showed you the before and after without telling you the truth, this could have almost been a successful case, but we all know what happened. So at that stage, the tissues were solid enough to insert a prosthetically driven implant in the right position, and then we did a secondary augmentation following the principles of GBR. At this stage, I had then to manage the most difficult part, which was, of course, the soft tissue dehiscence. Now, I normally do not position any connective tissue at this stage because the connective tissue should be inserted in a partial thickness pouch. But at this stage, I had no option other than reconstructing the soft tissue with a double layer connective tissue harvested from the roof of the mouth, from the palatal area, and suture it as best as I could to patch up everything, which is, of course, something that you just try your best of your knowledge to do it. There was no protocol. That's what I'm trying to say. There was no, in a way, science behind it. You just have to close because GBR has to be with a primary intention closure, as we know. Now, Delphine was then finalized. This is the final prosthetic restoration performed by Dr. Farhan, who works with me in London. So a really nice prosthetic result, but a very not attractive and unaesthetic final case. You may notice the black triangles, which, yes, we can claim and say to the patient that this was expected from the very beginning. But we have a small scar in the upper left area. We have definitely given her function, but certainly not aesthetics. And again, this is thanks to the low lip line that, in a way, we had nevertheless a satisfied patient. But this case has taught me an enormous amount of information. Now, I went into the complications field in terms of publications, and we have recently published a chapter on this new book of a bone augmentation by anatomical region by Professor Tzvi Artzi from Israel, who will be published in 2020, so literally now. It should be out in probably a month, and analyzing this. Now, obviously, I don't have enough time to go into the details, but I've tried to condense a little bit of my learning curve with Delphine in classifying what happens when we have this exposure of this new generation PTFE membranes, which we have seen, in fact, we can carry on watching them at least for a set number of weeks, which we do not have any specific data yet on how much we can observe them for, but we have come to this kind of conclusion. Now, macroscopically, we can divide our exposures into early or late exposures. Early exposures means in the first 2 months, and late exposure is from month 2 onwards. And even then, it depends when you have the exposure. So it is quite clear that whenever you have the exposure, whether it's early or late, and you have infection presence, there is nothing to do other than immediately removing the membrane and starting all over again, letting the tissues heal spontaneously. So removing the membrane, obviously removing the infected graft. If there is an implant, which hopefully there is not in the most severe cases, then that has to be removed as well. And this is one of the reasons why we tend in the vertical severe cases to augment first and then position our implants so that we can manage the complications better. On the other hand, both in the early and late exposures, if we do not see an infection like in Delphine's cases, then we need to observe and to plan the membrane removal. Now, obviously, this is very generic, but in the chapter, there is all the decision tree. And the most important factor is when we observe the patient with a non-infected membrane exposure of this new generation, there are two parameters that need to be very much monitored. One is the obvious presence of an infection if it comes, and that goes directly into the red pathway, or if the soft tissue, the histins, starts to become larger, exactly like in Delphine's case. And at that stage, that is the key to remove immediately the membrane and to proceed. Now, in general, complications are not only membrane exposures, as we saw, but you can also anatomically damage our patient, especially in the lower mandible, when we're talking about nerve or vascular damage. And this obviously brings me to suggesting you to read the beautiful anatomical paper that Isvan Urban has published in JPRD, if I'm not mistaken, in 2017. Infection. There could be a potential complication where the soft tissues are not dehisced, so they're not open, but unfortunately there is an infection. This may be due to the fact that we have tried in and out of the membrane too many times, we have fiddled, the membrane has touched saliva too much, and this could be a source of severe infection. Then we may have tooth or root damage. This is most of the times overseen and not said of, but sometimes we need, especially in the smaller cases, we need to remind ourselves that when we are pinning or screwing or tacking our membranes to secure them, we have to be careful not to secure them on the adjacent tooth root. And we have seen this several times with the students. Now, one other complication which is extremely important is the complications from implant placement, because we are positioning our implants after 6 or 9 months in what I call baby bone. So we really have to be careful. I would like to pay credit to Frank Renoir, who has published a book on the weakest link. Now, he was the first person to bring from the aviation field and from the medical field what we call the checklist, or why do these things happen? Do you remember when I told you that I have these cases on an everyday basis, and why is it that I have positioned that screw in the wrong position? So we always talk about technical complications, which we have seen intraoperatively, postoperatively, about how we actually perform, how we move our hands, how we do that flap, how we design that. But Frank has also told us why not focusing also on ourselves, on the environmental complications, on our attitude, on our knowledge, and why not also on our stress management. So these are things that obviously now we don't have time to get into too much details, but I think it's extremely interesting to recognize that we are in fact humans. We work and we are responsible for what we do. So there's no such thing as the wrong instrument or something that is somebody else's fault. In fact, we are working and we are responsible for our patients, and we are responsible to using the knowledge in the correct and humble way, ethically. So with a more positive note showing that if all of these parameters, both personal and technical, are followed to a specific protocol, and I like to highlight how much it is important to be very, very humble in learning how to treat these complex cases, I would like to thank you for your kind attention and invite you over to London when all of this really pandemic disease has ceased, hopefully very, very soon. Thank you very much.
Thank you, Isabella. That was an excellent presentation. Also, thank you for your willingness to talk about complications, very important. although of course I've seen that you have touched these very, very complex procedures that of course cannot be dealt with by, let's say, hundreds or thousands of colleagues. This is in the hand of the master clinicians. Now, I have two questions concerning your membranes. When I saw your case, that it reminded me on our early development phase, early 90s, where we have had, of course, without any knowledge, in about 30%, we had dehiscences and then infected the Gore-Tex membranes. And then I learned the hard way, if you don't take it off, when the moment you see some exudation, then you're gonna be punished heavily. So yes. It was impressive to see that you had such a good results underneath the membrane, despite the fact that the membrane was exposed for so long. Is that a routine observation? Because when you follow your protocol, or is this just a happy coincidence in this particular patient?
Well, the truth is that there's no literature behind this. So the truth is that I can answer only based upon clinical experience, which is what we normally do not like to do. And I'm talking to the master of science and publications and data. So when it comes to understanding why this is happening, the truth is that this dense configuration of the new generation membranes in a way block the penetration of hazardous bacteria from the extraoral cavity inside the regenerative area. So in a way it protects, if you may allow me this terminology. This is not all the cases, of course, but on a general note, again, from my clinical experience, I would say that a good 90% of the exposure rates that we see with the new generation membranes can be kept under control. And that's why it is important to monitor the patient, because things may change. We don't know why. But on a general basis, you may keep the patient with an exposure up to approximately 10-week time frame. The reason why I did not state this is because this 10-week time frame is still very controversial. We still don't have a specific timeline. We have a lot of studies to do before we can clearly state how long these exposed membranes can save the regenerative process underneath.
So the decision is often done with your gut feeling.
Correct. The decision is done also by observing the patient, and as soon as you see a sign of infection, which could be pus or bleeding or redness or the typical appearance of the soft tissues that you recognize immediately, then that's the moment where you don't have to wait a single day more and you have to remove everything.
Now, this single lady now, is this a situation you often see because you get this kind of referral? Because I hardly see these patients anymore since we know much more about post-extraction alterations. So patients or like the colleagues are actually, they know if they wait too long after extraction, you get these kind of atrophies. Why did she have such an atrophy?
Well, this patient had the tooth extracted only 6 weeks prior to when I showed you the first clinical picture. So in fact, the reason is I didn't show you, and I can share it with you, the actual picture that was sent to me by the referral dentist. The tooth was completely outside the bony envelope to start with. Okay.
So a unique situation, not very often, I guess. Huh?
No, because we know how to treat it in advance.
Now the PTFE membrane, what type do you use these days? How is the brand name?
So the PTFE membranes, there are two brands which may be completely equal. One is the Cytoplast, which is pure dense PTFE, which is a very well established and well documented membrane, and the other one is the Neogen membrane, which has a slightly different configuration. It has a slightly more expanded PTFE, but still on the denser side. So it is very malleable, and both can, and in fact, the two cases I've shown, one was using one and one was using the other one. So there's no conflict of interest.
Okay, very good. Now, I assume that you also use collagen-based membranes.
Yes, the collagen-based membranes absolutely may be used, but for a completely different indication, as you showed earlier on this morning. When we have a horizontal defect, even if it's significant, we would definitely opt for collagen membranes, because we all know they have many more properties in terms of even complications, given we're talking about this, and management. But when we have to reconstruct a 3D boxy shape in the vertical dimension, there is there is literally no choice if not using a self-maintenance in terms of space. We need the space.
Very good, excellent. Now, I'm sure we're going to hear more about that from Istvan, because it's so important to differentiate when to use the collagen-based membrane, when do you have to move to the PTFE membrane, because depending on the defect morphology and the objective you have for your regenerative outcome. Now, a last question from a colleague. He asks you if you have a large nasopalatal canal. Do you graft those canals or do you stay away from them?
No. We don't graft the canals for various reasons. In fact, a canal is a four-wall defect. So if you think of the biology behind a four-wall defect, you definitely do not need to graft anything because the blood clot would do its own work. But we try to avoid, and even the case that I showed you with the bleeding, which looked not very significant, but it was actually very significant, has taught us the lesson to try to be extremely gentle, lateralize as much as possible the bundle, and avoid obviously breaking it. This is the mission number one.
So, thank you so much for this contribution. Excellent lecture. It was a pleasure to see you again in such good spirit.